Hi, this is Brian Kim. I'm going to share with you case number 86 in the best way to do cataract surgery series. This is a Catarock, and I'm going to show you how I'm able to disassemble this lens using double chop and cross chop, mechanically fracturing the lens into smaller pieces before I emulsify the lens pieces. By doing it this way, I'm able to reduce ultrasonic energy use, and because I use less energy, I feel like this is a safer way to disassemble this Catarock lens. So I'm using a cotton tip to hold the eye, and then using corneal marker to help me with the sizing and centration of my rhexis. I'm making my paracentesis incision first on the right side and then the left side, making sure the incision is flat to the iris plane to create a nice corneal shelf to achieve a self-sealing incision. This is intracameral lidocaine and then some intracameral air. I'll be injecting some trypan blue to paint the anterior capsular surface. I'm just very carefully wiping the dye on the surface of the lens. I don't like to just flood the eye with the dye. I just like to paint it like a paint roller effect. And this is the dispersive viscoelastic to coat the corneal endothelium and also pushing the bubble out. And this is a triplanar corneal incision. I make a vertical groove at the limbus, place the blade into the deep part of the groove, tunnel into the cornea, and then when I want to enter, I turn the eye towards me and enter. I push some more viscoelastic to fill the anterior chamber and flatten the anterior capsule. Because this is a dense lens and there might be some zonulopathy, I go ahead and go straight to the cystotome. So I'm using a cystotome to cut the capsule and create a little bit of a tear, so hopefully I can get a flap here. And these are the rhexis forceps. I'm grabbing that flap, and the dye was able to stain the capsule nicely there. I'm going around carefully, grabbing and re-grabbing. In my experience with these very dense lenses, there's a higher chance for zonulopathy, and so that's why I switched to the cystotome rather than going to the puncture technique. It just went straight to the cystotome in this case. So finish off the rhexis, burp some viscoelastic out. And this will be the capsular fornix hydrodissection technique. I place a cannula underneath the rhexis edge contra-incisionally, point the tip down towards the nerve, try to get a nice wave. Of course, the lens is so dense, I'm not sure if there was a wave, but I'm able to decompress on the left side, turn the cannula tip down on the right, and you can see the lens is able to spin. So now this is the phaco. I'm adjusting the sleeve length, irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. You can see I've exposed the sleeve quite a bit, so I can maximize my ability to chop with the phaco tip. Removing the epinuclear material, placing the chopper underneath the rhexis edge, contra-incisionally, pointing the phaco tip vertically sub-incisionally, bringing both instruments together, crushing the lens in the process, dividing the lens once the instruments are brought together, separating the instruments so that it fractures the lens in half. That is a double chop, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing and dividing that right heminucleus in half, and that is the cross chop. Lifting the first quadrant up with some vacuum, crushing the lens piece and sandwiching it, and then using some ultrasonic energy to emulsify the lens piece. Crushing it and then dividing it again. So that's the first piece. I'm rotating the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, dividing the two pieces there in half, separating them, placing the chopper around that piece again, pulling it centrally toward the phaco tip, dividing that piece in half and separating it. Using some vacuum to lift that quadrant up, crushing it and dividing it between the chopper and the phaco tip, crushing it into smaller pieces using successive crushing forces, and emulsifying the lens piece. Rotating the bulk of that lens in front of me again, grabbing that smaller piece with a little bit of vacuum. Once I've grabbed it, get the chopper around it, and then crushing the lens piece. Whenever I'm crushing the lens piece, I'm not using any vacuum or ultrasonic energy. Whenever I'm crushing it, I'm just using the phaco tip as a chopper. And so there's no need for the phaco energy or the fluidics during that maneuver. Plus, when I'm chopping it, it might be close to the iris or the posterior capsule, and that's not really the time to turn on the vacuum. So place the chopper around this last quadrant, pulling it centrally toward the phaco tip, and then carefully dividing and separating that lens piece, placing the chopper around that piece again, bring it towards the phaco tip, and then crushing it. Using a little bit of vacuum to position the lens piece, and then crushing the lens piece, and then emulsifying the lens piece. You can see I'm very carefully positioning the lens piece between the chopper and the phaco tip so I can crush it with mechanical forces. By doing it this way, I'm reducing the use of ultrasonic energy. Again, very carefully sandwiching the lens pieces into smaller pieces between the chopper and the phaco tip, and then emulsifying it. Placing the chopper around that piece, dividing it into smaller pieces, and then dividing that next piece in half as well. I'm just breaking it down into smaller and smaller pieces using mechanical fracturing forces. And once the pieces are small enough, I'm using some vacuum to hold it, crush it into even smaller pieces, and then emulsifying the lens pieces. Once most of the lens is out, I become much more mindful of the posterior capsule. You just want to make sure that the posterior capsule has no reason to go up towards the phaco tip. And so I'm very mindful of that, and I'm using very sparing amounts of ultrasonic energy and vacuum with these maneuvers. So I take the chopper out, and I'm pushing some more viscoelastic to coat the cornea, as well as pushing some viscoelastic and tamponading the posterior capsule. So now there's a lot of viscoelastic coating the corneal endothelium, as well as creating a buffer between the phaco tip and the posterior capsule. And just with pure mechanical forces only, I'm able to divide that lens between the chopper and the phaco tip, and then again doing it successively. And once the pieces are smaller, and once the piece is on the phaco tip, I go ahead and emulsify it. If the lens piece is not on the tip and you activate vacuum, all you're going to do is remove viscoelastic, which is pointless. You want to crush the pieces into smaller pieces, but you don't want to activate the vacuum and aspiration until the lens fragment is on the tip. So again, I'm able to carefully remove each of those pieces, being mindful of keeping the chopper deep between the phaco tip and the posterior capsule. I'm able to remove those small remnants along the way. That are in the incision there. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. I'm adjusting the sleeve, turning into the subincisional space, making sure there's no hidden cortex there. Since this is a dense lens, I'm very mindful of my vacuum. Look at my vacuum. Even though I'm in Cortex mode, I'm not using maximum vacuum in these cases. Again, dense lenses I equate with weaker zonules. You can accidentally grab the capsule and cause some zonular stress. And so I'm just being very careful, using foot pedal control to make sure I'm polished underneath the rhexis edge to remove the cortical material without stressing the zonules. So I was able to catch a nugget on the INA tip there. So I hold it and then I'm mashing it with the cannula to clear the tip. Once I do that, I switch to polish mode and more aggressively polish underneath the rhexis edge of lens epithelial cells. I'm polishing the posterior capsule as well, polishing subincisionally as well. So go ahead and use a cannula and pulsing BSS into the subincisional space, being mindful that I'm within that space and not at the iris plane. You saw I liberated some cortical material subincisionally by doing that maneuver. Go ahead and inject some cohesive viscoelastic to fill the bag. And I switch to the capsule sweep. I'm going to polish underneath the rhexis edge on the left side first. And then on the right side. For these dense lenses, I always put in a 3-piece lens. I worry about zonular weakness in these cases. So because of that, I have to widen the incision. So I'm using a diamond blade, making sure I widen the incision. And when you cut, you want to cut a little bit higher. You want to cut into the roof. You don't want to cut downward. So this is a 3-piece lens. It's going into the capsular bag. I turn the bevel to the left. As the leading haptic is delivered into the bag, it's going to come out planar. As the optic is delivered, you want to rotate your wrist, pronating it so it rotates counterclockwise about 90 degrees. So the optic comes out flat. The trailing haptic should come out pointing to the right. And then I use a Maltzman to dial in the trailing haptic. I go in without irrigation and then activate irrigation, go under the lens, removing the viscoelastic from within the bag, and then removing the viscoelastic from the anterior chamber. Switch to polish mode, polishing under the rhexis edge of any potential lens material there. Trying to turn the lens gently here. And then I'll go ahead and hydrate my incision. So this is a dense cataract, a Catarock. You saw double chop, cross chop, mechanical fracturing techniques, very carefully, systematically breaking the lens down by crushing it between the chopper and the phaco tip. You saw I'm able to crush it into smaller and smaller and smaller pieces. And once the pieces are small enough, I try to emulsify those small pieces. By doing it that way, I'm able to use sparing amounts of ultrasonic energy. As you can see here, the CDE is 4.01. This patient had a clear cornea post-op day 1, despite a very dense lens. And so by doing the cases this way, I'm always very confident that I'm able to do my very best to keep the cornea protected as much as possible, even in these very challenging, dense cataract cases. So I hope this was helpful to you, and I thank you for your attention.